Very good afternoon, everyone, and welcome for this special webinar on tracking public health nutrition policies in India and the current first 1,000 days strategy to reduce child undernutrition. We are privileged to have Dr. Sheila Veer, a very senior public health nutritionist, founder director of professional organization that is Public Health Nutrition and Development Center, which is she's one of the most senior and very active nutrition public health professional in the country. Dr. Veer has completed her post-graduation from Delhi University, and then she got the degree, a doctorate degree from Queen's University, UK. She has over 35 years of experience in public health and nutrition space, with started a career as a nutrition officer, worked there for 20 years, and she has provided professional services to the in the both strategic and technical leadership for policy formulation, program designing, and implementation of nutrition programs in India, Kazakhstan, and Maldives. Dr. Veer was elected Secretary of the Nutrition Society of India 2004 to 8. She is a recipient of Commonwealth Countries Award, Sri Lanka and Sri Lanka NSI Memorial Lecture Award, and the Kamlapuri Sabharwal Oration Award. She has over 100 publications. Additionally, she has edited as well as authored 3 books on the subject of public health nutrition in developing countries, child and adolescent nutrition in India, policies, programs, and progresses. These books are currently being widely used as a part of curriculum in various postgraduate teaching institutions and as a reference book for nutrition program persons. Madam, welcome to this special webinar, and over to you, Dr. Sheila Veer.
Thank you, Dr. Jyoti Sharma, for such a wonderful introduction. And I thought a topic like public health nutrition policies in India would be a good idea for audience who are possibly may not be getting into learning from the past, and we need to learn where we are today. Actually, there is much progress, there is persistent malnutrition, but it is not the same scenario it was long back. So with these words, I will now today track the shaping of the public health nutrition policies in India, and then come to some little discussion on 1,000 days. The first part of my presentation will be on 5-year plans, then come to the Niti plans, and then come to the research that went into to formulate policies. So let's have the second slide, please. Yeah, next one. So Constitution of India stated that states shall regard raising the level of nutrition, and it's not coming, the full thing is not coming on the screen, but I can read it. Why is it not coming? The state shall regard raising the level of nutrition and standard of living of its people and improvement in public health among their primary duties. And after that, next slide. So every 5-year plans, we had nutrition featuring in the policy development, as I mentioned. Yes. Next. So these are the 7 debates of progress. I will take you through each box briefly. And just to point out how we moved from hunger to today's portion strategy. Next one, please. I don't know how many of you know that we have, in 40s, we were actually, when post-independence, we were actually shortage of food was our main problem. And this followed the Bengal famine of 1943, where 3 million people are reported to have died. And it all led to acute food shortage and clinical nutritional deficiencies, such as having, so there was a lot of focus on improving food availability situation in the country, and PL480, that is, we were being supplied food from the US as a PL480 assistance, and this was to avoid hunger. actually, and then we moved into self-sufficiency stage. This, many of you are familiar with the word Green Revolution of 1960s and 70s, which was in fact introduced by from the Mexico experience, and which Mexico experience on how to use technologies, how to use seed variety, etc. Besides, of course, chemical fertilizer, and various other issues of agricultural policies agricultural experience were brought in. Also insecticide was introduced, which we today complain, of course. And then we started, the wheat production became sufficient. But as you can see that there was intensive public cry for food, and we had a ration scheme which was strengthened, as well as during this period, I think we need to appreciate that there was intensive public appeal by the then Prime Minister. I always find it interesting to share it with the nutritionists that there was a movement in the country which was called Jai Jawan, Jai Kisan, where every family had to sacrifice one meal as cereal, one meal, and sacrifice cereals in one meal. That means in 7 days, one day would go cereal, one meal would go cereal, please, not one day. And I have gone through it and enjoyed eating baked vegetables and various other food items which are normally cooked at home, no cereal. So we went through such an intensive drive so that we could sustain cereal availability. When we looked at the food production, next we thought, okay, the protein quality is not good. Now, at that time, we were not thinking of protein quality. As you will see the subsequent slides, that we kept thinking of a new dimension. And protein quality on reducing gaps in dietary protein consumption was a main problem. And so the research was directed not at increasing as much on pulse production and availability, though the milk production revolution took place as white revolution, but on producing weaning foods or weaning food mixtures. A lot of home science colleges prepared food from conventional and unconventional sources of protein, and these were available. These were not marketed, but these were made more still in the laboratories. But Balahar was one production which was produced from 6,500 tons. It went up to 50,000 tons. It was actually a mixture of groundnut flour, soybean flour, cottonseed flour, etc., etc. And that was being distributed as a protein source to improve protein quality in the food. Then the wheat fortification with lysine was also brought in, because lysine was seen as a gap in our cereal. So lysine fortification was included, and there was a lot of technology. It never came as a program, but there was a lot of experimentation going on. I thought I will share. In fact, when we talk of today of fortification of cereals, when we talk of fortification of cereals, I think we should also think of fortification of cereals with amino acids. The food era and the protein era was then followed by applied nutrition program. Very interesting. Here there's somebody talking.
Request everybody to please keep themselves on mute.
Shweta Keswani is talking, I think. Okay, we can stop it, please. So, applied nutrition program was introduced. Applied nutrition program focused on production of fruits and vegetables. And today we are talking of Poshan Vatika, so it is very similar, but we don't look at the experience which was implemented in over 1,700 blocks in the country. There was a technical consultation, there was an evaluation, and we discontinued it in 1978. It has come back again. Then elimination, then the focus from this food production, availability of protein went into observation that there was a lot of clinical nutritional deficiencies, mainly of vitamins and minerals was the focus that time, and also of protein energy deficiency, which was initially thought as protein deficiency, kwashiorkor, marasmus, iodine deficiency, goiter, vitamin A deficiency had to be eliminated, anemia had to be eliminated. So I will talk about this in detail later on, but at this moment I would just mention that we did a lot of research before coming into it. Parboiling as rice was introduced to prevent vitamin B deficiency, and we had a lot of other experiments on supplementation and fortification. I'll discuss it later. Now I'll focus in the 4th and 5-year plans where there was a big, this is a great milestone in our understanding, but we shifted from protein gap to energy gap in kwashiorkor and marasmus. The problem that I see whenever we look at shaping of policies, we forget the other nutrients. So now we started focusing on energy gap and forgot about the protein forgot about the protein, and focus was on energy gap. Though there was some focus came into feeding also. The feeding was focus was mainly on non-discarding colostrum. Exclusive breastfeeding issue had not come. Colostrum and complementary feeding. Time of complementary feeding, how to make home complementary feeding mixtures were introduced. Special nutrition program was introduced actually before ICDS came in, and it was a result of a UNACCSN consultation, the UNICEF WHO guidelines also on supplementary feeding. There was a lot of international discussions on on feeding, supplementary feeding, and special nutrition program was brought in India. And we had Balwadi programs, we had nutrition rehabilitation centers were not implemented by the government. Interestingly, I have visited this NGO managed program in Sini and also in Tamil Nadu by Dr. Venkat Swami, where the focus was on looking after severely malnourished children. We didn't distinguish, it was kwashiorkor, marasmus. We didn't talk of SAM then separately. And they were managed with the feeding of children, kitchen gardens were introduced. Nothing much came out of it, and no guidelines were prepared at that time. And so it remained mainly with the NGOs and academic institutes. And all these programs were influenced by international recommendations, United Nations Subcommittee on Nutrition, not by India producing evidence, which is interesting. Next one, please. Then comes before that launch of ICDS. Before ICDS, supply nutrition program was a welfare program, and then keep this as a development program. It is not said, but you can see the association. ICDS was launched in when there was a movement on UN child rights movement, and there was a national policy on children that was brought in 74. But India had already, as I showed you, we had experience of supplementary nutrition program in Balwadi, and also an interesting project, which was a Narangwal research project, which was undertaken in Punjab in 10 villages only. And it was a health system project. It is not documented that ICDS came from this, but if you look at the data at the same time of 1973 project, it showed very effective results on nutritional status. And I think Narangwal research project must have helped in formulating policy of ICDS. We also had for the first time national data. We had national data, NSSO, and NNMB 1973 came in. These all helped us to form the policy, and ICDS started with 33 projects. You are very familiar with all this. And supplementary nutrition policy was brought in. Again, I'm emphasizing there was no research on this. It was mostly driven by the UN consultation. I don't know how many of you know, you're all familiar that today ICDS is universal coverage, but it started with 99 beneficiaries per 1,000 population. We used to refer to it as 99 ka ankara, because it was fixed number of pregnant and lactating women, fixed number of 7 months to 3 years children, fixed months of children over 3 to 6 years, 59 months. Now, what used to happen when I used to visit a village and I used to ask an Anganwadi worker, aapke paas kitne lactating mothers hain village mein? They would invariably tell me 8 to 10, because that was the entitlement for supplementary nutrition. So it did not, the program also did not go beyond 99 beneficiaries normally, because that was their working population that they worked and concentrated on. And that was a disadvantage. I'll talk about it, how it was discontinued, but you must know about it. And free supplementary nutrition started getting, this is an unfortunate period, I feel, as well as supplementary nutrition got equated with, solution to resolving our undernutrition problem. I'm not talking about micronutrient deficiencies. And this was questioned by some experts who always sought evidence, but till today I haven't seen evidence on it. I have seen how much is the coverage, how much is consumed, but what is in its impact? I think we need some good studies, good control studies. Then came the era when the health sector also came in, and ICDS system also came in a big way. And but the Supreme Court order came in, and it said from target we should go to universal approach. In 2004 it went. So you can see that 1975 it started. We had a very targeted approach for supplementary food. It was made universal only very late. And there was a feeling that state level nutrition missions needed to be created to push the program at the state level. And in the era 1997, 2007, we had state level nutrition missions with different names of great politicians. In Maharashtra, it was on the name of Shivaji's mother. MP and UP. UP had no name. MP was, I think, on Atal Bihari Vajpayee's name. And then we have ICF experimental stages, community mobilization, positive deviance, etc. was studied. Now there was interest in IYCF along with supplementary food, and ICDS system led the way. HAL did not come along. It was an ICDS driven project, and there were a number of projects done, which you must have heard, Dular project. Earlier than this, there was TINIP 1, TINIP 2, which is very well documented, and one must study it to understand Tamil Nadu Integrated Nutrition Project, because they call the ICDS worker community nutrition officer, community nutrition worker, then CDPO community nutrition officer, and it was a very nutrition driven project, and it's a very interesting dimension of ICDS that one needs to study. These IYCF experimental strategies focused mainly on breastfeeding, some focused on complementary feeding also, but focus primarily remained on breastfeeding and timely introduction of complementary feeding, nothing more than that. Health sector came in that time, and as you can see now, we have two parallel systems which was created. Though ICDS system was in social welfare, it became in the Ministry of Women and Child. Health sector, national health policy came in, and then you have the national rural health mission coming in. And micronutrient implementation were being looked after, being intensified by the health sector, and they were being intensified, baby-friendly hospital initiative, SAM institutional management, IYCA policy guidelines were issued, but the health sector remained responsible only up to breastfeeding level. So we can see a bifurcation, though in practice we kept thinking that they're working together, but I wonder. At least I did not experience that till today. High priority to nutrition turning point that I see is NFHS 3. And why is it so is because at that time we came to know the trend in what is the NFHS new growth chart had come in, WHO 2006 child growth standards, where India was also part of the 5 countries which was from where the data was taken for forming this standard. And we had data on under 6 months. So we could plot nutritional status for 0 to 6 months also. And it was a turning point because I'll show you that we'll talk about 1,000 days, then you will see how this helped us to go forward. Next one, please. So now Niti Aayog came in after this, and have you missed out any slide? No. I think you missed out the 12th 5-year plan. Yeah. So the window of opportunity was thought about 1,000 days because as you can see that I'll show you the graph where we see that stunting increases rapidly in the first 2 years of life. Low birth weight onwards, it is a problem. So first 1,000 days, we'll discuss that later. At the moment, just note that village health nutrition days were introduced, newborn care was introduced, HBNC program, child health program, diarrhea management, zinc was introduced, MCP card was introduced. These are all under the health and ICDS sectors. Unfortunately, the roles and responsibilities are not very well defined. And we had a very well drawn out comprehensive nutrition strategic plan in 2011-16, which is referred as Addressing India's Nutrition Challenge 2011-16, which is what is current program is quite dependent on that. MN implementation was strengthened. We have the weekly IFA policy coming in, and the biannual vitamin A supplementation program was brought in. Biannual vitamin A supplementation, I will discuss in detail WIPS and biannual, so I'm not getting into it at the moment. These are all evidence-based. So when Niti Aayog comes in 2014, we go to national program in a mission mode. Before that, government had a program called multi nutritional program was there, and mission mode we had brought in mission again. A national program is considered important. Till now, we have not announced the mission. National Nutrition Mission was announced then in 2017. What helped in having the mission mode is nutrition data of NFHS4, then WHO targets, CNNS data, Lancet 2013, which talked of underlying problems of malnutrition besides immediate, policy vision of the expert group, advisory group on nourishing India. And then we had a lot of new programs coming in besides health nutrition mission. Under the health sector, we had Anemia Mukt Bharat, MA program, which focuses on breastfeeding mainly, and institutional breastfeeding environment to be introduced. HBYC, which goes beyond the neonatal period, young child period, and food fortification, where FSSAI standards were finalized and fortified twice through social feeding program was announced in 2021. These are we also started working on nutrition sensitive programs, such as Swachh Bharat Abhiyan, which addressed the issue of water sanitation. Now comes the current program, which is Poshan Abhiyan. And it was actually Poshan Abhiyan was followed by 162 blocks being covered in 8 states under ISNIP program with World Bank support, which is piloted as ICDS system strengthening and nutrition improvement project. These are interesting projects. A lot of learning has gone into in the Poshan Abhiyan. Strategy-based past learnings of 1,000 days that I mentioned, that there were a lot of experimentation community programs were woven into this Poshan Abhiyan. There was priority to aspirational districts and focus on both essential and nutrition sensitive interventions. So we talked a lot about multiple sectors coming in. Poshan Vatika concept was introduced. Jan Andolan campaign, which is a campaign approach, was introduced. And you must be all familiar with the common application software that was piloted in the earlier phase until 2021. And today it is replaced by Poshan Tracker. So in 2021 February, we had a new program that we talked about, Saksham Anganwadi and Poshan 2.0, and guidelines have been issued, and these are the focus areas. Next one, please. And though we call it a multi-sectoral program, I see it as an ICDS-centric program with focus on, now there is a little focus on health and nutrition education with reference to infant and young child feeding. And Jan Andolan is strengthened. Computerized monitoring. When I went to the field this time, I saw a lot of use of Poshan Tracker. There needs to be a lot of monitoring of entry in the Poshan Tracker that I observed, but some of you may have more experience. And special care on first 1,000 days, which I'll talk about. 270 days of pregnancy and 730 days of under 2 years, as well as newly married who must enter pregnancy healthy and well nourished. So I think the program focuses on adolescent also. And home visit was emphasized, which is now linked to the Poshan Tracker. Supplementary food, Poshan Vatika, food element still gets a lot of importance, and ICDS infrastructure strengthening. So, and essential nutrition interventions such as IFCF are being talked about, but multi-centric approach feasibility needs to be really genuinely tested whether it's happening. Next one. So what shaped PHN policies in India in the 7 decades? Mostly it was observation driven and influenced by UN scientific guidelines, UN Subcommittee on Nutrition, Advisory Committee of UN, and international conferences, scientific experiences and evidence. It was also influenced by national surveys, NNMB data, NSSO data, then came NFHS 2, NFHS 1, 2, 3, etc. And key learning from national and state pilot projects and evaluation findings and consultation. And some were research driven, which I will talk about separately now for your interest, because we must know there were projects which are research driven in our country. Rights approach, as I mentioned, ICDS came under child rights, and we had the food rights coming in 2013 and 2014. It was rolled out as a policy, and synthesis of experiences that all shaped the policy, and implementation experiences also affected it. These shaped the India's nutrition policy. I will like to go into details of evidence research on policy and operational guidelines. This I have experienced, and I think it's important for students of public health to know how research got into the policy stage in Indian context. So next, first we'll deal with iodine, then anemia, then vitamin A. First iodine, then vitamin A, then anemia, and then we'll come to IYCF and fortification. Universal salt iodization program you are familiar with, but this is salt. This was based on a Kangra Valley study which was undertaken in 1956 by All India Institute of Medical Sciences under the leadership of Professor Ramalinga Swamy, and it was found that potassium salt, iodate salt, is effective. Though we have US and Switzerland already having iodized salt, India did not adopt it till it had its own research on it. And Kangra Valley experiment is very well known. And USAID program on food fortification. On food fortification is also a great contributor for us to learn about the current ongoing experience on food fortification. So this is 1956 to 1962. As you know, India introduced a fortified salt with potassium iodate and not potassium iodide. So then National Goiter Control Program was launched after this experiment, and it was limited to sub-Himalayan region of the country. Then NFI has contributed, Nutrition Foundation of India has contributed a lot in NGCP program, as well as in, I think, our IMS Act in India, because they had undertaken a study also on feeding practices in India in 84. So NGCP policy was formulated in 1984. It was under Ministry of Health. Technology of fortification was defined, and it was felt after the NFI evaluation, it should cover all states and not be limited to sub-Himalayan region. And participation of private sector was also considered important. Otherwise, the production of iodized salt was done by only public sector production units, and it was a very meager amount that was produced only for sub-Himalayan region. There were lots of problems of making it universal. Next one. At the same time, there was a lot of studies going on internationally, which made us understand that iodine deficiency is not only limited to goiter. It is a wide spectrum of problems of physical development, brain development, fetal brain damage, and loss of IQ points. So it was internationally, it was felt that it was should not be called National Goiter Control Program. It should be called National Iodine Deficiency Disorder Control. And prevention of iodine deficiency was positioned by India also as world's single greatest cause of preventable mental disorders. That's how it got the focus and it got the attention of the public. Because we focused not only on goiter, we focused on the other issues which are not visible and are not considered to be part of iodine deficiency. The International Council for Control of IDD and India Council was also found to bridge the gap between research and application. And India, in 1990, announced its resolution to eliminate IDD by 2000, which we have done very successfully, which public health students who are participating here should know. 1992 policy came on National IDD Control Program, and the strategy was USI, Universal Salt Iodization. Then it was thought it has to be made mandatory. Bans were introduced, national bans which were came in, were lifted, then reintroduced, and then what worked was the definition of salt under the Prevention of Food Adulteration Act itself was redefined, and to salt, edible salt containing so much of iodine. It was defined. Next. With all these measures, salt production was accelerated in the country. Fortifications level was standardized. Procurement policies. Salt Commissioner's office was based in Jaipur, was the nodal. Health was the nodal overall technically, but program actually was dependent a lot on Salt Commissioner's office, where I worked very closely and went to salt works. Because unless we iodize salt, nothing would, program couldn't be rolled out. Creating demand per se wouldn't work unless the salt is available in the market that is iodized appropriately. Public-private partnership helped, and government had restriction on refined salt. Refined salt policy was revisited and it was made more open. Iodization capacity was increased. Iodine, it is imported from South America. So that was brought in. There was we have the subsidy policy on iodine that is imported in the country. We had a big problem of small salt producer, which exists with most of the food items that we have in our country. Cereals also, we have it with wheat also. But we resolved that problem because small salt producers started harvesting salt and feeding the refinery, giving it to refineries. We had a very big problem of Bargara salt. Bargara salt is this bada dhela salt. This is called bada gada salt, isliye iska naam Bargara hai. Bargara salt. And this salt, if you made it into powder and iodized, it would become into rocks again. So the technology has been developed in the country. It used to be contributing to 30% of the salt in our country. And it was, the technology was brought in, and Bargara salt was introduced as iodized salt in packaged form, eventually. Otherwise, it used to be sold on street sides. Iodine would be superficial, washed and gone. So we had a lot of work. What I'm trying to stress is that for every program to come in, how much work has gone in? Distribution and packaging. In fact, in 90s, when I started looking into the program, we didn't know how much salt was moving by road. We knew by rail because rail movement was controlled by Salt Commissioner's office. Only iodized salt. And then policy on packaging also came in. Sun logo, smiling sun logo got printed, but it was not made a policy. It was producers and distributors to use it. Legal, I told you, it became mandatory. And what worked a lot in our country is introduction of salt testing kits. I don't know how many of you have seen it, but salt testing is if you put a drop, it changes color. And it changes colors, and it could monitor the quality of salt. How much iodine specificity was not that good, but it created a lot of mobilization and sensation. Though we had salt producers lab, salt producers always had a laboratory attached to their own production unit. Government had their laboratories at the state level, which was monitoring. But what worked was the salt testing kit at the community level. Demand creation with the bills and posters and all did not work. What worked was Doordarshan broadcast of iodized salt spots. That really made a difference. And state as positioning message on brain damage, lower IQ and all. To my experience, it really affected the wholesalers in the non-salt producing states who would then buy only iodized salt because they at least I used to advocate with them that if you don't bring iodized salt, you are damaging brain of our children in the state. And that used to really hit them. And they used to say, okay, ma'am, how do we bring it? Where do we get it tested? We will only bring iodized salt, because they used to buy iodized salt from salt producing states. And you know, the salt producing states, leading states are Gujarat and Tamil Nadu and Rajasthan. These are the three leading ones, and the other ones are smaller ones. Next slide. So the production, against the target, you can see the production has really gone up. Ignore the line which seems to be, target seems to be out of focus here. And the production went up from 1970 onwards. You can see in 18, the production has gone to 6.8 million metric tons. Next one slide. And when you look at the NFHS 4 and 5 data, you can see over 90% houses are using iodized salt. Now we come to vitamin A. How did vitamin A program come into our country? Vitamin A surveys showed we had a lot of clinical vitamin A deficiency in the country. So you now see the improvement. We don't see clinical manifestations of eye, which was affecting like Bitot spot, keratomalacia, and children were going blind. That has been resolved. Primary causes were low intake of vitamin A and recurrent infection. So National Institute of Nutrition brought in the testing iodized, vitamin A solution in oil syrup form. 3 lakh units were tested, and no other country in the world had done that. In India is the first one to introduce it. Next one, please. So initially it was introduced in 7 states, and but we never thought of 3 lakh units. It was always 2 lakh units were introduced as in a policy in 7 states. And there was an interim evaluation also before we expanded it. And the policy was how to reach the children. It was done a crash administration, but we realized that it was not reaching children. So what we have done, we will show you. There were studies done on production and supply, how much vitamin A is produced in the country. It also produced from lemongrass oil. That was also studied. And can we synthesize in our country was studied. We were still dependent on vitamin A coming from outside. And improving vitamin A supply situation and according to high priority of vitamin A policy got really attention when we linked vitamin A deficiency with child mortality. Next slide, please. And National Vitamin A Prophylaxis Program moved to National Vitamin A Management Program, Control and Management. So India multicentric study was done on impact of vitamin A supplementation under 5 mortality. And one task force, technical task force was formed by the government of India. And for the first time in 1990, we introduced 1 lakh unit for children 6 to 12 months. To associate reducing severity of measles, there was research in NIN which showed the severity of measles episode is reduced when you give vitamin A supplementation. But India did not agree, rightly so, to no vitamin A supplementation was introduced for 0 to 6 month children, which is that in many countries, no maternal vitamin A supplementation is there in our policy. Dietary vitamin A rich food consumption got a higher attention, and so did food fortification of oil. So we revised from a prophylaxis program for prevention of blindness in children, it was called, to vitamin A policy, prophylaxis of management of vitamin A deficiency, and it was integrated in Child Survival Safe Mother program of Government of India. And as mentioned, that the 2 doses are there, 6 months to below 6 months, 6 to 12 months, it's 100,000 IU, and 6 months to 5 years, it's 200,000 IU. And it was actually in the second phase, 3 to 5 years children were not included, but they were reintroduced in 2007, and we have it now 6 months to 5 years children getting vitamin A. Vitamin A rich food, breastfeeding was promoted, so was food fortification. And as I mentioned, international focus on vitamin C supplementation under 5 mortality rate in the World Summit for Children 1991 pushed vitamin A program in the country also. But we were concerned about the low coverage, so let's speak what we did. So pilot projects were introduced. I was very actively involved in it in UP. And we fixed 2 months in a year because 6 months gap you have to give vitamin. June and December, we experimented in Bahraj district of UP, and then it was scaled up in 18 districts of UP. And it was a pilot project where it was a 1 month allocated to be given vitamin A along with vaccines. When an ANM would come with vaccine box, she would also carry vitamin A syrup bottles. Vitamin A is still in syrup, lot of syrup gets spilled. but alternatives were tried out but did not work. So we have vitamin A in syrup form, and biannual fixed month strategy is now in the country as a part of the reproductive child health program. Next one, please. So, and NRHM2 and biannual strategy is there all over, and we have NFHS data, which I'll show you, and diet diversity is now built in portion 2.0. Next one. So vitamin A supply coverage, when you look at NFHS2 and NFHS3 only measure at least one dose of vitamin A supplement in the age 12 to 35 months, whereas NFHS3 onwards, we measure vitamin A supplement given in the last 6 months, at least one dose. Next one. So you can see the doses has increased. Prevalence of clinical vitamin A deficiency, there is a significant reduction. Nutritional blindness, which used to be 2% in 1971, has disappeared. We have Bitot spot, which is less than, which is mentioned, but it is not seen as much today, except in few areas of the country, and especially after drought. Anemia, today it is seen as a burning program, so many of you are familiar with it. But in fact, India started the program in 1970 and as a National Nutrition Anemia Prophylaxis Program for women and children, and it was not dependent totally on international data. We have our own data. National Nutrition Anemia Control Program came in, then introduced the WIPS policy, which is weekly IFA supplementation. Then National Iron Plus Initiative, which is a life cycle approach, and Anemia Mukt Bhata, which is today's program. And food fortification, which is based on the standard policy of where rice atta. We have all details. Rice has been rolled out. Double fortified salt has also come in. Next one. So first anemia policy was, again, it was a great work by NIN and ICMR, and National Institute of Nutrition based it on the anemia prophylaxis program. When I looked at the original guidelines, it says it's a preventive program, so IFA to be given to women who are non-anemic, if you please. It was news to me when I read it. Nobody had read it because iron was given to all pregnant women. But the policy said it should be given to only non-anemic women. ICMR evaluation was done in 89, and then it's picked up momentum in the country. And national consultation looked at India's field trial undertaken by Dr. Sood of All India Institute of Medical Sciences on usage of 60 milligram of iron, 120 milligram of iron, 180 milligram of iron. And he, as a member, a senior member of the task force, suggested we should change from 60 milligram to 100 milligram. So iron doses in IFA composition was revised from 60 to 100. Duration was revised from 90 to 110 days to 100 days. Now it's different, as you know. And IFA supply, you can never imagine how much struggle we went through to get it from open to package strips. IFA was given in open bottles. A mother would just put her palla in front, and the health assistant in PHC would just count some tablets and give it to it. There was no special focus. But then package strips came after a struggle of a long time, really. It was a Herculean task to get it in. And it was then incorporated in CSSM in 92. In fact, IFA supply in package strips came in around 1999, if I recall. Next slide, please. Then you have the National Nutrition Anemia Control Guidelines, and we have Childhood Anemia Policy Guidelines came in. They were all merged in. Weekly IFA policy in India came in as India's efficacy trials that were conducted in 3 locations of India, Baroda, Delhi, and Mumbai, on daily IFA tablets versus weekly IFA tablets. And weekly IFA tablets were found to be effective. So that was considered in the National Consultative Meeting, and weekly IFA was approved and directed for district level piloting. So pilot projects were launched in the country, and there are a lot of publications on that. And following that, there was an international discussion on whether weekly or daily should be taken. There are 2 lobbies. Eventually, weekly IFA was the one which was taken as the best program practices. And we also analyzed the best program practices on rolling out the program in 10 countries, which I did actually for UNICEF Manila, and a fixed day approach was found the best strategy out of the 10 case studies. Global, only 10 countries had it then. 213, India issued WIPS guidelines under the NIPI policy. Then came the National Iron Plus initiative. Most of you are familiar, but anyway, I'll mention. WHO global targets pushed it. That is World Health Assembly global targets pushed the interest in anemia control. And a life cycle approach of NFH, NIPI was given a lot of focus. Supply chain, SBCC strategy, all these have been actively studied till date. And there was no treatment doses that time. And data wasn't available. Treatment was said to be 2 tablets per day of 100 milligrams that time. But there was no data. NFHS 4, NFHS 5 did not provide data on the treatment dosage. We only have data on first on 100 tablets. Now we have on 180 tablets. 218 came Anemia Mukt Bharat. You are familiar with. This is how the policy was shaped. Next one, please. Next slide. Possibly is the last one. 218 AMB was launched. As you all know, it is the life cycle approach. It's 6 by 6 by 6 strategy, 6 institutions, 6 targets, 6 interventions. Targets are defined. Now it is the tracking strategy has been added. Targets have been defined. IFA supplementation, diet diversification, food fortification. These are doses has been revised, as you know, in AMB, and with the new findings that have come in. National Center of Excellence and Advanced Research on Anemia Control has been established at AIMS. IFA supply and logistic management studies have been done intensively. We have studies on NB. So it is a very high priority program today because we are concerned about the high percentage. And policy on AMB operational guidelines. I have seen the training manual, but I'm still looking for operational guidelines. How do we reach? I have operational guidelines I've seen for weekly IFA, but for ANC, for children, official guidelines are not there. Policies are there, definitely exist. Next one, please. Next slide. And if you look at consumption of IFA tablets, you can see there is an improvement. Lot needs to be done. We are still below 50% in most of the states, and at least 80% coverage and compliance has to be there if you make a difference. Data shows. Next one, please. Next one, please. Next slide. Now, we are now back to our interest in higher attention to, we realize there as well, era where we were only thinking of micronutrient and breastfeeding. Now we are looking at in IFCF in totality and also maternal feeding issues in the first 1,000 days. So there is higher attention to MIYCF, that is EBF has increased, exclusive breastfeeding has increased, but underweight and wasting below 6 months has remained high. Why? Possibly EBF, exclusive breastfeeding itself is not effective. And how there are experiments undertaken by Dr. Rupal Dalal's team, which has shown cross-cradle hold technique works. What works is, besides proper latching, also is emptying one breast before going to the second one. Hind milk and fore milk all need to be taken into consideration. And first 14 weeks need intensive attention of progress in weight gain. And care of the low birth weight needs attention, though we say 2.5 kg. Median is, the WHO median in the percentile is 3 kg, so they believe in 3 kg. And any child who is below 3 kg needs special attention because 2.5 is in fact a risk group. Below 3 kg, we can do a lot, between 2.5 and 3 also. Evidence shows that 30 grams per day weight gain daily can be achieved compared to 17 grams per day, which we talk about. So this is there's a research going on, and we need more research on complementary feeding also and maternal feeding. Rice fortification has been rolled out. Let's look at the results. Next slide, please. We can see that baseline to end line, we have children 7.5% decline, 8% decline in women, and 4.6% in men has been observed and reported in Chandauli district, where a study was undertaken and a pilot scheme. So what are the challenges when we have shaped the policy? We can see from research we have come to policy which is well defined, policies comprehensive, implementation guidelines or rolling out guidelines remain a problem. Unlike health program, if I look at public health programs of antenatal care and I look at immunization, we define every step from supply to reaching the child and child being administered vaccine and followed up. I think we need to have implementation guidelines which defines every step and who is responsible. And so we need to do implementation research. We are ICDS centric, but we have to come to a stage where we need to understand, is ICDS in health doing parallel jobs or they are working with the same children? And is there convergence? Let's not talk of convergence as a word, but as a reality. Is it cost effective? Again, we need an implementation research to do. If health led the program, or IC led the program with roles defined, would it work better? Is it working okay this time? I think we need implementation research and not take it for granted, the convergence. And system of reaching 1,000 days is also needs to be worked out. So 7 decades of efforts, I have gone through all these boxes for you. I'm sure it was enough. And you can see from reduced decisive hunger in the first to third year 5 plan, today we are working on the National Nutrition Mission, Poshan Abhiyan and National Health Mission. And we have a long way to go. I will now in the second phase just focus on the 1,000 days and then end my presentation. Just 5 slides on that. Next one, please. You know, India has decreased in stunting rate, but is still about 36%. And compared to other Asian countries, which is not showing here, we are still rather high. Come next, we are more interested in the later part. Show me, next one. And we see stunting has declined at least 3 points in only 3 states, Bihar, Manipur, Sikkim. It has gone over 3 percentage points in some states. So NFHS 5 is showing that there are lots of problems which we have to resolve. Next one, please. Monthly capita consumer expenditure has also gone up. Poverty has reduced, but still we have the nutritional problem. 1/3 of children are still stunted in the country. Next one. Look at the consumer pattern. We can see that cereal production is the shaping the policy. We have enough cereal. In fact, cereal intake has gone down according to NSSO 2024. And we have food intake is taking less of money, percentage of cost of consumer expenditure than it took before. Initially, if you look at the data of 70s, it's as high as 74%. Here it is at least 50%. Today, it has gone down to between 30 and 40% in rural and urban areas, which is interesting. But what is disturbing is that consumption of beverage and expenditure on beverages has gone up. Next we come, I'm just pushing this just to show early childhood stunting. Again, we have this data. Now I'm coming to 1,000 days, NFHS 3 and NDFBC, that is the Delhi cohort study. We see the stunting increasing up to 24 months steadily and then leveling off. Yeah, and this is the worst time when mental development is taking place. Physical development is also sharply taking place, and brain development is almost 80% completed. Next. And it is irreversible. Data of NFHS 4, this is NFHS 5 shows the similar trend in stunting and wasted. And that's why we think the first 2 years, that is 24 months, are the most crucial. Adult height is set at 2 years of age. Brain development is also set at, is also 80% complete by 24 months of age. The significance is evident. And if we go to a village where 1,000 population and we look at under 2s, the population, the number of households will be much less to work with, and we could make a difference. So focusing on first 1,000 days is important. Next slide. If you look at the stunting prevalence in all regions of the globally also we see the incidence is much higher in the, prevalence is much higher in the first 2 years of life, not in 2 to 4 years. You can see it from red dots. Anemia in children also, Dr. Kotecha has shown that it also peaks at 24 months in children. Next one, please. Then when we look at now, this is under 5 childhood deaths also, we see, first we used to talk of neonatal mortality in the newborns, the first month. Now first to 23 months also, we see the contribution is very high. So first 2 years, more deaths occur before 2 years of age than any other time in childhood. This is an interesting, so we have to bring public health and nutrition. The goal is To reduce childhood mortality, we'll have to reduce childhood stunting. And we'll look after the children first. So first 1,000 days is the pregnancy period of 270 and 630 of the first 2 years. Next slide. It's taking time to come. So major pathways for reducing statins, we have to look at the life cycle approach, inadequate pregnancy care, we have to intervene, reduce low birth weight, improve birth outcome, child care in 0 to 24 months, optimum attention to growth, which is largely irreversible. Adolescent growth, if we can't look after, at least let's look at, as I've shown in the next box, newlyweds who will be, if we can reach them, the next pregnancy, they will be prepared. Because I think in a big population, we have to reduce the number of households and make the maximum impact. So next one. So our challenge is implementation in the first 1,000 days. Policy exists, but I think our attention on AMB cycle is there. When we are talking of anemia, we are forgetting undernutrition and even overweight is increasing. It has become 3%, 3.4% from 2.2 to 2.4%, 1% increase between NFHS 4. Improving MIYCF. I know we talk about MIYC and MICEN, but I'm talking about food. Maternal infant child feeding is crucial, and we must really pay a lot of attention to this immediate determinant, that is on feeding care, and then linked to ANC, how we link up feeding with the ANC cases, exclusive breastfeeding, how can we make it effective, and we have to make a lot of progress in complementary feeding. Even the timely feeding we haven't. Then is the major question where I mentioned implementation, which sector maps under twos, child nutrition risk, child death risk families. Is there data on coverage of nutrition intervention in first 1,000 days? Who is responsible? ICDS Health, because each ICDS, is it really reaching under twos? Health is reading, then are we using the optimum contact with mother and child of health sector to make a difference in MIYCF? Are the roles of health as ICT sector defined? These are the questions I'm leaving with you. Are we matching the opportunity of delivery program for first 1,000 days intervention through existing ICDS in health? I think these questions we need to do through implementation research, and who can do it better than today's students? So moving forward, we need to act now. Newly married in first 1,000 days, right time, key interventions, implementation research, trials on redesigned cost-effective systems, operational studies, which is most effective system. Do we depend on ICDS Health as we are depending today, or they can be a revised system which could serve better by combining the two somehow? How to combine? We need an implementation research. Next one. So newly married pre-pregnancy in the first 1,000 days are crucial for as a high priority for public health nutrition. Next, I will only show you some books that have been published. Next slide. References so that you know of it. This is being used by Delhi University, I know. It is available in Amazon. It's called Public Health Nutrition in Developing Countries. The second edition is available. And it gives a lot of information, program as well as technical, because I think technical issues need to be rolled out in programs, and I see gaps in information. So I try to write these books so that we can fill up these gaps. Next one, please. And this focuses on India and child, adolescent, and women nutrition India. This edition by KW Publishers is available for South Asia. We have another publication by Routledge. Next one. On child, adolescent, and women nutrition India, which is published by Routledge. This is for international. It's not available for South Asia, I'm told. So that's it. Thank you very much. I hope you found it informative. Thank you very much.
Thank you very much, ma'am, for this insightful lecture today. There are a few questions. If we can take up for the question answer. Is it okay?
Yeah, it's okay. Sure, do please. Yeah.
Yeah. So there are quite a lot, but I'm just going to pick a few. Thank you so much for this insightful webinar. There is a question from one of the students. I wanted to know that what should be new public health professionals keep in mind while working on policy formulation, considering the change from undernutrition in the country to the overnutrition, obesity in the country and the world?
I think the genesis of the problem is the same. And I think it's the feeding issue which we have to be careful about. What are the children eating? How are we feeding them? Are we using wrong foods? Selection of food and feeding practices. I think we are overindulging. Sometimes we are underindulging. And while we are overindulging, we overindulge in not taking care of fatty food, sugary food, processed food, etc. And the child's stomach is filled, they don't take nutritious food. So I think and underweight also, and you also know that low birth weight also increases chances of obesity and overweight. So maternal nutrition care is also important. So I would look at it. I personally feel I think we need to pay much more. Health has taken over rolling out of vitamin A and IDD, and we are focusing on anemia. But I think on feeding program, we are really not serious, and we need to become more serious in child feeding program. As we say, we don't even have evidence on what is being fed to a child and what is and how it is showing results, except one study in UP, which I know of. We don't have much evidence on it. And Dr. Rupal Dalal is also coming up with a lot of evidence. I think we need to push much more on feeding issues. And when we talk of exclusive breastfeeding, is it effective? That is not much of a problem, but sometimes we tend to give both. We give breastfeeding also, and we give formula milk also. So children are overweight. And then again, after 6 months, we start giving food which is very high in fat, high in carbohydrate, high in fat. We are not serious about it as public health nutritionists. I think we need to be more serious.
Yeah, thank you so much. There is another question from Sini, Kolkata. Sweta wanted to know that if we can refer to the phantom growth chart for the preterm and low birth weight babies instead of WHO growth chart. She has this question.
Which growth chart? I did not get the first one.
Phantom.
Okay. WHO percentile growth chart is what I would like to depend on for low birth weight, and WHO percentile growth chart very clearly talks about low birth weight babies. Girls should be minimum 3.2 if I remember, and boys should be 3.3 kg at birth. I would go by WHO percentile.
Right. So I think another one which is very interesting, after VA's policy, the vitamin A supplementation, to 1990, it took nearly 28 years to stress upon management policy in anemia, yet to realize its potential. What should be some key barriers on actually getting from some lessons we can get from that?
Yes, it did take a long time, and I don't think management program was 1990, 1970. 1970 was the first program. 1990 was the second one when it was revised in 1990, and vitamin A biannual strategy came in 1997. So when it took 20 years, this is what I'm trying to show, that every program takes a lot of time, because initially it was only in 7 states. And then because we need to, once we come with a policy, we need to test it operationally as well as effectiveness. We had only tested the effectiveness. And then we did a program operationally. So we lost time. When we did effectiveness, we took it up to scale. And then when we're doing it to scale, we realized we are not reaching. Why are we not reaching? Then we came to biannual strategy. So I think there we lost it. And I think even vitamin A supply was being imported. So there was a little less interest unless we showed the effectiveness also. And that is where the gap remains. So learning is that when we come up with a policy, let's have also how built along with what. Normally we push what and forget about how. And how comes later on when we see the less coverage, or we see the program is not disappearing. We have very good policies in the country, but rolling it out is a problem, implementation is a problem. So vitamin A is a good example that how implementation was getting affected and how it delayed the rollout.
Yeah, I think we can keep on going. Madam, I consider you as an encyclopedia of public health nutrition policies in India. Actually, it's been such a pleasure to hear you all the time. Whenever I meet you, it's such an inspiration. So thank you so much for joining us today. And it is such a pleasure to hear your thoughts and actually taking us through this journey of public health nutrition policies, which we often not hear from anyone actually, those who can actually take us through how these are evolved. Thank you so much, ma'am, for your time today and such an insightful talk. Thanks a lot.
Thank you, Dr. Sharma. I really enjoyed and thank you for the invitation. And thank you, participants. I see almost 100 of them. And I hope there's a lot of learning for us to move forward and move urgently forward. Thank you very much.
Thanks a lot.